Jesse Chason with Lisa Blanchard as the host of Airing Addiction.
I share often my journey started on this campus. Got sober as a client here, just like you.
I really do see phenomenal change.
Always hope. I've seen situations that on the surface look impossible become possible.
Doing this podcast is to share those recovery stories, be honest about what the challenges are and have some real conversations, but kind of share that out on the airwaves.
Welcome, everybody, to another episode of Airing Addiction. So glad you clicked on the link, watching this on YouTube or live, or however you like to consume your podcasts. It is not lost on me that we have quite a following of listeners. Just this week, somebody randomly came up to me that I know and said, "Hey, I've been listening to that Airing Addiction podcast." So glad that this message is getting out there. And really excited for our guest today to have what I am sure is a deep and riveting conversation. So I will turn over to Lisa to introduce who we have today.
Thanks, Jesse. So welcome, everybody, to July's podcast. I'm actually really excited for our guest today, and I'm really passionate about the topic that we're going to talk about today, and I know that he is too. With us today, we have Dr. Sharif Nankoe. He's the Chief Medical Director for our very own at Spectrum Department of Corrections Programs in the State Department of Corrections, and his expertise is treating opioid use disorder in jails and prisons, which is what we're really here to talk about today, because we're going to talk about kind of why this is needed, how we do it, and kind of what are some of the challenges and some of the opportunities with that. But Dr. Nankoe has been involved in the establishment of over 20 correctional medication for opioid use disorder programs. He is responsible for all of the medical oversight of our programs, but previously he was the medical director for the Vermont DOC Medication for Addiction Treatment Program and worked in the Vermont Hub and Spoke system as a medical director of 2 opioid treatment programs. So for those of you who don't know what Opioid Treatment Programs, OTPs they are programs that provide medications for opioid use disorder and include methadone treatment, as well as 2 office-based opioid treatment clinics, and is board certified in addiction medicine and family medicine. So we have quite a treat today. We've got quite an expert with us, but really also a really fantastic person. So Dr. Nankoe, Sharif, tell me a little bit about kind of how did you end up choosing this area of work as a physician?
Oh my gosh. So I grew up in a family. Well, first of all, thank you very much for having me here today. I'm so excited to be with you. I have always had an interest in social justice issues and taking care of vulnerable populations. Oh my gosh, if there is a vulnerable population, it's our incarcerated population. And when we're talking about substance use disorders in particular, about 65 to 85% of all people that are locked up meets DSM criteria for a substance use disorder. And the majority of all crimes that are committed are substance involved. It is crucial that we treat this population. The majority of all crimes committed are substance involved. And when you look at the numbers, about 17% of all state prisoners report regularly using opioids in their lifetime, and about 19% of jailed jailed inmates report regular use of opioids. So that's quite a number, and it's really crucial that we treat this population before they go back out into the community.
That's so fantastic. And this is something that is relatively new, right? Like I think even Spectrum is kind of the first of its kind to offer all 3 forms of medications for opioid use disorder across an entire state correctional system. There have been others certainly that are doing this fantastic work nationally in both jails and prisons. What do you think took so long for incarcerated populations to actually be treated for the substance use disorders that they have had forever, right? Like what do you think caused that delay?
Absolutely. I think it's there's a lot of stigma about the disease, right? For a long time, addiction was seen as a moral failure or mental weakness as opposed to a chronic medical condition. We can think back to the 80s where we saw all these ads about the war on drugs and, which our government continues to wage. And that's how it's been treated. That's how it's handled by the criminal legal system. And it's only with like the increasing literature over the last 10, 20 years where there's just more evidence it is a chronic medical condition. And it's just taken time for that concept to be accepted. And it continues to be something that we are working hard on convincing the criminal legal system that this needs to be treated as a medical condition. If you look at like 2017, 2018, less than 1% of all jails and prisons offered treatment for opioid use disorder with medications. And now that percentage is more like 30 to 43% of facilities that offer medication. So we've made a lot of strides. Good.
This is well needed. Sharif, thank you so much for all the work that you've done in Vermont with us. I'm sitting here and I'm hearing these statistics and I'm thinking even, quite possibly could be higher just based on the stories that I hear and the lived experience I have. And, you talked about the majority of crimes being somehow linked to a substance use disorder. And I can tell you without a shadow of a doubt that was my lived experience in active addiction and so many others. So today being able to get this vital medication in correctional settings, it's been needed for a long time. And 30% today, that is phenomenal. That is way better than it was just a few short years ago. However, I'm just thinking, how do we increase that number? What can we do as treatment providers to help spread the message, spread the word, and get this in 30, 40, 50% of institutions or greater?
Yeah, there's a lot of resistance to adopt these programs. Massachusetts has been at the forefront of providing these medications. And I think there's pressure from lawsuits on other states to accept, that treatment needs to be, treatment programs need to be created. It's following the standard of care and just encouraging and sort of honestly forcing facilities to follow the standards of care for medical practice like they do for other diseases. I think that's going to be unfortunately key part because there's so much resistance about this. Yeah.
Right. It's really about putting substance use disorder on par with other chronic conditions, that it's a human rights issue to be able to receive treatment for that, even when you are incarcerated or in jails or prisons. That's really a human rights issue that takes some time to shift, because some of the perspective that's been around, and we've been working in the correctional system for over 2 decades in various ways at Spectrum, and is that, well, somebody committed crimes, they should just have to receive that punishment. They shouldn't get support or treatment that's different from that. And simply the time alone in an incarcerated setting should be enough to kind of take care of the addiction. Can we talk a little bit about why that's really just not true?
Yeah. Opioid use disorder is a chronic medical condition. It doesn't just miraculously get cured when somebody doesn't use or is forced not to use. That disease process continues to be present. There are a few sort of different points that come to mind. Even if, there's this notion that jails and prisons are sober living environments, and unfortunately they're not. Patients continue to have exposure to opioids. And so their disease process continues to run rampant, even in these controlled environments. And then, of course, when patients leave, there is such a high risk of overdose death that the medical literature has made clear, right? Over 120 times the risk of an overdose post-release from incarceration compared to somebody in the general population. So it is, absolutely critical that these treatments are offered. The diseases don't just miraculously get cured; they need treatment. There's interesting research that was done by Liz Evans from UMass Amherst, and she basically looked at the life course of addiction. And what she found in her research is that if a patient has been stable in recovery for 5 years, that they've sort of changed their life course and that they're more likely to attain long-term recovery and do well. And corrections is perhaps a perfect time for that, right? Like a patient, you can really get them stabilized with the right supports, the availability of medications and psychosocial supports. That's the perfect time to stabilize them.
I love that point, because instead of viewing time in incarceration as kind of this forced time to just be away and having us, we all know in addiction, and those that listen, those with lived experience know that any kind of geographic cure does not work, right? And that includes incarceration. And that's not treatment, right? That's not stable recovery. That's the difference between reduced use, because we've already talked about the fact that use does not necessarily end 100%, even though it's harder to get, you can still get it, or even abstinence, right? Even if somebody had, pretty significant periods of abstinence, abstinence does not equal stable recovery, right? And those are two different things. In our opportunity in correctional environments is to provide the supports, just like we would in the community, that support stable recovery, so you can get to those kind of 5 years and beyond. And in a lot of ways, some of the ways in which that I think when I train, and I did a lot of this when we first started the programs, or I speak to correctional settings, I've done a lot of coaching across the country, is recognizing that the goals of the correctional environment and the goals of treatment providers are not necessarily different all the time. We both would like to see someone not come back to jail or prison, right? Like that's part of our goals as treatment providers, and it's part of the goals of the correctional system, right? Reducing that recidivism. And if you can build that stable recovery while you have someone with you connected to psychosocial supports that may be harder to access in the community, or just there's a lot of other competing needs happening in the community, maybe that's a real opportunity to impact those numbers.
Yeah, that's so true. And in fact, when thinking about recidivism or rearrests, reincarceration, there was an interesting study that came out of Western Massachusetts. It was published in JCOIN, that showed that patients with OUD who were offered treatment during their incarceration were less likely to recidivate, or they were less likely to be rearrested and reincarcerated compared to those who are not offered treatment. So there's very clear literature about that too.
That's so great. And, us as treatment providers, certainly I'll speak for myself. I come at this from a very biased point of view, because I see every day that these type of medications work to help stabilize patients and help get to that 5 years, or even, that first year where, life has been so unstable for so long. And then it's like, oh, made it to that year. Maybe that was the big benchmark for somebody. I'm just wondering, again, from my own lived experience, and certainly I've shared on the show with our listeners, and just sharing with you, Dr. Nankoe, that, my lived experience had included county jails numerous times. And I'm someone who is a testament to treatment reducing recidivism, because it wasn't until I went to Spectrum that I haven't been back to jail, unless it's been with some type of recovery group sharing a message coming back in. But a memory comes to mind where I was receiving services, dental services. I was in a county jail in Massachusetts. This was probably 2007, 8, somewhere around there. And I needed some dental work done. So you go down and you go to the dentist, and it doesn't just happen right away, right? There's a long wait. And there was a fight. There was a fight that took place in the waiting room. And then I did whatever dental work I needed to be done. And then I come back for follow-up. And because of the fight, Now there's cages in the waiting room that you're literally locked in while you're waiting. And I'll just be honest, that deterred me from ever going back there again. Like, I didn't get in the fight. I didn't participate in it. I saw it. I was impacted by it, but I never went back to that dental provider or any medical provider for the rest of my time in that institution. So from a practical point of view, because I know some people that are listening to this, I'm sure have a lot of questions about how does that work? If people get in fights going to the dentist, then you introduce this medication. How can we do that safely in a correctional setting? If you could just speak to that for a moment about how this actually gets done on a daily basis.
Yeah. So it's important to of course realize like these are supposed to be controlled environments. Again, opioids have penetrated many correctional facilities. But the way that these programs, and Jesse, are you talking about the actual like medication process or?
Yeah, because I can just see, we talk about stigma and, I'm thinking, big picture, maybe someone's listening to this in another state where these programs haven't yet been in a county or a state setting and they're kicking around this idea. And I can certainly see that being a, top question they would ask.
Yeah.
How can this, from a protocol standpoint, how could we make sure this happens in a safe, controlled environment?
Yeah. I mean, the screening process is a key part of this, right? We want to make sure that we are fairly and appropriately screening patients for participation in the program. And that should be done in a very organized manner. And as I mentioned before, in terms of numbers, about 20% or so of the population is likely to have this disease and will need treatment. And here we're talking about prisons. In jails, that number is going to be higher. All right. So just thinking about the volume of patients that are going to need treatment, it's something that's going to be a pretty significant operation. So just having that in mind in terms of appropriate staffing of security, appropriate level of staffing of medical and nursing staff. And yeah, when somebody views our medication line, it's quite a process, right? Like patients line up and they are screened by security and we make sure that they safely receive their medication. And if they're on buprenorphine, that they are given as much time as they need to allow the medication to dissolve. And then there are further mouth checks before the patient is sent on their way. So that's quite an operation, right? Especially if it has a facility has like, over 100 patients on that. That's not something that's done quickly necessarily, especially if a patient is on buprenorphine or if you have a substantial number of patients on buprenorphine.
So it really seems like, as important as this is, and we are all in that camp, that really jails and prisons need to have some buy-in to this process in order to allocate the resources and the time and the supports in order to make sure that that happens, whether it's with contracted providers or it's in-house staff or medical providers. There's lots of different ways that this can be done depending on the medication and depending on the setting, but it does take a fair amount of investment. And so really it's that discussion of the benefits of this really do outweigh the front-loaded kind of, challenges of having to put one of these programs in place, which probably better than anyone, having opened over 20 programs, in multiple states. How do we kind of shift that perception that this time and effort is worth it when there is still so much stigma out there?
Yeah. So what we have found, or what the literature has shown, is that disciplinary issues behind the walls go down with these programs. We see that our patients do better during incarceration and they do better post-release. There's very clear evidence that the rates of overdose post-release go down with these programs. We have robust data from California where they the California's prison system has it's the largest MAT program, correctional MAT program that's in the United States, and very clear trends of decreased overdoses during incarceration as well as post-incarceration, decreased hospitalizations for skin and soft tissue infections, decreased rates of hepatitis C. And we're seeing that, I mean, their data is the most profound and clear. And there are many other, there's much evidence from other parts of the country as well. So it's really clear that there are many, many benefits.
So we know what the solution is. We know what the problem is. It's about getting from point A to point B with the, I guess, end goal of reducing recidivism and reducing medical and reducing disciplinary reports and reducing all these things that, like Lisa said a little while ago, treatment providers and corrections, we share a lot of goals, right? I'm sure if you asked any warden of any prison or anybody that had to do with the administration of the day-to-day activities in a jail, all those things would be on their bucket list of goals as well.
Absolutely. I actually think that these types of treatment programs and corrections or security, they have the same goals, right? Like if a patient is not doing well on a medication, that's not good for the patient. It's, medically, we don't think that's a good thing. And security doesn't think that's a good thing, right? Like we're all sort of on the same page. And we all want that patient to do well, right? So I think sometimes, especially when these programs are created, that there is sort of like a tug of war between security and the medical operation of these programs. And I don't think that's really needed. Because if
when
the patient
people
not
feel
doing well,
better, they act better, right?
Exactly.
Like,
yeah.
And Jesse, from the perspective of lived experience, we know that when you're really not feeling well and you're in a cycle of use and withdrawal and active addiction, even if it's shifted a bit because you're incarcerated, you don't feel well, right? And so when we don't feel well, then we don't respond well to our environment. And correctional environments are hard enough as is. So when you're also not feeling well in a challenging environment, that just creates more disciplinary reports, like more challenges, more impacts in the milieu setting. And but when we can help people feel better, and that's not just with the medication, right? The medication absolutely does that, right? Because it manages those symptoms of withdrawal, manages some of those urges and cravings, all of the things that the medications can do, but it's also all the other things that come with the treatment, right? The psychosocial support, the counseling, groups, when you can manage groups, which are sometimes challenging to do in correctional settings. But all of those wraparound supports that can be provided to somebody work together with the medication to help people feel better, right? And work towards that stable recovery. Like I'd love to have a unit of a bunch of people in stable recovery versus a bunch of people in active withdrawal, like that. Those two spaces are going to look very different.
Yeah. Well, it's also important to think about, like we talked about, the 30 to 43% of jails and prisons that offer treatment. It's important to think about like who they're treating. Mm-hmm. Most of these 43% offer continuation of treatment, right? So they're not necessarily doing new inductions, right? So new starts of treatment, like a patient coming in from the community in opioid withdrawal. Less than half of these programs offer inductions for people coming in without medication, right? So a big sort of improvement would be if all these programs offer inductions, right? And then also pre-release, an even smaller number offer treatment or new inductions to patients who are about to leave. Yeah. So there's a huge missed opportunity given those high overdose rates post-release.
Took the words out of my mouth, Dr. Nankoe. Of you said 120 times likelier to overdose upon release. And, I'm reminded of a patient I had, not with Spectrum, but at another halfway house location. And he was on a pretty substantial dose of methadone, north of 100 milligrams. And this was years ago, before there were methadone programs in the county jail he went to. And he came back. Luckily, he made it back into treatment. And he would tell me about just the horrendous experience of detoxing from that medication cold turkey. And I know as treatment providers, we've all heard those stories, I'm sure, but I think it's important for anyone interested in this topic. You bring up a great point of, we're continuing this medication that somebody's already on. It would be pretty ridiculous if someone was on high blood pressure medication and then incarcerated and then abruptly taken off their high blood pressure medication. Yeah. And we know again, to your point, Lisa, of a whole unit in active withdrawal, that's not going to be a fun place to live, work, experience, be a part of. And, I think some of the successes we have as a treatment provider is that now, I know I've worked personally with patients who have had legal involvement, and all within the Spectrum continuum of care are able to receive this medication regardless of where they are.
Right. Yep. And then the other issue that we should talk about is that, again, while about 30 to 43% of all jails and prisons offer the medications, less than half offer methadone.
Yeah.
Right? And so what we have found is that many of our patients do a lot better on methadone, right? It just depends. Some patients do better on buprenorphine, some patients do better on methadone. And it's so key to have both, or really all medications, including Vivitrol, available to really tailor the care to the individual needs of the patient, right? And so, of course, there's more, it's more difficult to set up a methadone program, right? Spectrum has a ton of experience with that. But it's key that all of these programs make methadone available in this environment.
Yeah. And the regulatory challenges are a part of it. SAMHSA did release a final rule which gives some flexibilities that may help that in some areas where that has not been the case. So some of it is absolutely regulatory challenges but some of that is also stigma, right, against all the forms of medication, including methadone. And so that is also something we have to do some more education on, and try to break that stigma, right? That all forms of medication need to be available. And I think to your point earlier, Sharif, that not everyone and not most programs are doing new inductions. Just as important as not removing somebody from their medication for opioid use disorder, from their high blood pressure medication, we wouldn't have somebody who presented with acute disease or presented, for example, with high blood pressure that we chose not to treat and be like, you know what, you're incarcerated. We're not going to treat that. We're just not going to. But that is what we say when we don't offer new inductions for medications for opioid use disorder.
That's right. Absolutely right. And I think that from my perspective, the most interesting sort of population that is vastly being ignored for treatment are those mid-sentence individuals, or those individuals who have, for example, life sentences, right? That's ignoring, again, the fact that there's so many opioids that are penetrating these facilities. And so, maybe if you had truly a sober living environment, maybe you could make an argument, right, that the patient is safe and, that there's a therapeutic community there and they might do well. But in my experience, that has not at all been the case, right? So it is absolutely key to offer treatment to that population as well, right? Because these patients, in the meantime, are continuing with very risky behaviors. They're getting sanctioned for their ongoing attempts to use. It's rewiring of the brain. They're going to do what they need to do to obtain opioids. Even in this, and they get in even more trouble in this environment that's controlled, and there's
Yeah.
significant punishment for being caught, and it just may add on time to their sentence, or they may lose access to canteen, or they may lose their facility job, which are all things that are beneficial to them and therapeutic to them. And ignoring that population is something else that needs to be worked on.
Yeah.
So.
Great point, Sharif. And the cycle of addiction doesn't stop just because of where you're living. And all those things, as I'm thinking through my own lived experience, I mean, there was a time where I was in another county jail that was the drug block, quote unquote. There was a little bit of access to treatment back then. Like I think it was a group a week or something. But my experience was there was more access to substances in that block that was supposed to be programming, because we had these greater privileges that were, again, in active addiction, the wiring of our brain, we're using whatever we can to get that substance because we think that's the solution. I'm just wondering what can you see? Obviously, you have an immense experience with this subject matter. What can you see coming down the pike in the next 5 or 10 years? Anything new, anything different, anything just a better way to treat these populations that we're discussing about?
Yeah, so I certainly see more and more of these programs coming online, which is absolutely key. I think there's more sort of like federal state pressure to establish these programs. And I think a big game changer is going to be the injectable formulations of buprenorphine. That's going to be key. Think about all the sort of resources that go into medicating these vast lines of patients that need treatment. When you have the injectable available, it makes things a little less burdensome and a little easier for the patient. Like they don't have to get up every day early in the morning to medicate. It just makes things a little less burdensome. Resources are tight in many correctional facilities, right? Like there's like anywhere else, like anywhere else in the medical world, or there's staffing, unfilled positions, and that's medical security. These programs are getting the job done with these limited resources, but having the injectable available will be beneficial to the patients and these programs. So I see that as a huge game changer.
Right, because the movement through facilities can be really challenging, right? And it can disrupt the treatment process, the medication process, the counseling process. And so when we can reduce that impact of having to manage movement, I think that's really helpful. And so one of the things I wanted to touch on before we run out of time is, we talked a little bit about that high risk of overdose post-release, and I've done a lot of coaching and consultation nationally. And one of the biggest challenges that jails and prisons have is not having all of this time, effort, and great treatment options go to waste if somebody doesn't continue medications as soon as they leave, right? The whole point of offering this for those that are releasing, right? There's lots of benefits that you described for those that might not be releasing, right? And we still would want to do that. But that high risk time post-release is still really significant. And one of the challenges is making sure that individuals connect with community providers, right, when they leave. And I do think that from great evidence is something that we do exceedingly well at Spectrum. So I wonder if you could speak to a little bit about that process, maybe how recovery support navigators support that transition to the community.
Yeah, Lisa. So yeah, as you mentioned, the post-release care of the patient or the care at release is key, right? Like making sure that the patient's insurance is turned on, making sure that we have established care for the patient in the community to have a place to go, that they have bridge scripts available if they're on a buprenorphine product, that they have Narcan available. That is all work that is done by our recovery support navigators. We want to make sure that that the patient has a safe place to go and has these supports to be successful. Our recovery support navigators will go to the appointments with them to the first appointment, like whatever, literally anything they need to do to support that patient at transition, because it's difficult. It's so difficult. And Jesse, I don't know if you have any thoughts about that, when you went back into the community. For Spectrum, we are exceedingly good at providing this support via our RSNs. Our follow-up rate in the community, like the number of patients that make it to their first appointment, is over 90%, which is better than most hospital discharges. Most of those patients that leave the hospital for
Way
whatever
better.
medical problem
Way better.
way less. It's like less than 50%, right? So we really understand at Spectrum how important the post-release period is, especially the first 2 weeks, and we really we bend over backwards to support these patients.
And it's relationship building. So I was part of the very beginning of the Recovery Support Navigator program when we put that in place in the Department of Corrections in Massachusetts when they first started naltrexone. And so some percent of individuals would receive a Vivitrol shot prior to leaving. And what was different about this role, which was really kind of groundbreaking a little bit, was that the same person that would connect with you in the community did InReach while you were incarcerated. Right. So they built a relationship. We're part of reentry planning. We're part of developing the systems that you're going to need in order to be successful upon release, but also built a relationship with you, so that there was some trust, so that maybe they would meet you literally as you left, right?
Yeah.
Whenever possible, right? Or shortly thereafter, or be at that first appointment. But, there was someone there who you had a trusting relationship with to help manage the things that get in the way, whether it's insurance coverage, or the best laid housing plans that were set up just fell through the second you left, right? Or other competing needs kind of got in the way and you missed that first appointment. How do we make sure that you can go back the next day and see someone so that you don't fall back into a cycle of use and addiction? And I've seen lots of different ways this can be done, right? Like I do think that this particular focused role on, that's my job, right, is to support that return to the community, and is very helpful. But of course, it requires funding for that position to be paid for. Some other jails I've worked with have used peers, right, which we talk quite a bit on this podcast about the power of lived experience, right, Jesse?
Oh, yeah.
There's ways that you can do it even with different levels of resources, but I think that relationship while incarcerated and connection to supports when you leave is really kind of the magic sauce there.
Yeah, absolutely. And to build those relationships that you talked about, right? Like our RSNs start meeting with the patient 120 days before release.
That's
right?
great.
To really work on that, develop those relationships and continue to follow those patients and be available to those patients for 90 days post-release. So
that's phenomenal, Sharif. And just to go back a few minutes, you had talked about my feelings getting released, and then released. My experience was driven right to the door of Spectrum by the sheriff's department, and I'm sitting here. I don't think recovery support RSNs were not a thing back then, and maybe had they have been, I might have gotten here earlier than I did, because there were many best laid attempts by providers that just went out the window because there's a fear of the unknown. I remember standing at the doorstep of Spectrum, and my honest to goodness first thought was, I want to run away, but I don't know where Westboro is. I grew up near Boston. Like, which way do I run? That was really what was going through my mind. And the only, grace that I had going there was, I opened the door and there was somebody there. I didn't know them. I got to know them pretty quickly because that recovery specialist did my intake that day. But it was, seconds and inches, and recovery support navigators have a phenomenally crucial job in that, 120 days prior, 90 days after. I mean, you're talking, that's a good chunk of time to develop a professional relationship.
And one of the things I'd like to make sure we say, and we talked a little bit about, the stigma against medications and the idea that even if you provided a recovery therapeutic environment, that should be enough. But we also know in community-based treatment that states and communities that don't offer medications broadly and only offer residential and don't have multiple pathways, their overdose rates are higher, right, per capita. Like, we know that that's what happens in communities, that we need to offer all the supports, right? So, residential treatment, peer support, multiple mutual support, therapy, counseling, all of those things can absolutely be important parts of somebody's recovery journey. But if we don't offer medications because we believe that that's not necessary, right, either in the community or in incarceration, we're missing that opportunity for what does that person's unique recovery pathway need to look like in order for them to be successful. And so I think, that multiple pathways approach includes medications, right? Some individuals certainly go through incarceration, go through community programs without medications and enter long-term recovery. We're sitting here with someone in that space right now. That doesn't mean that that's the case for everyone. And if we lose you on day 2 post-release to an overdose, then we miss all of those opportunities.
Yeah, well said, Lisa. It's about, again, seconds and inches, providing as much support as humanly possible. And I talk often to people who are in recovery who have some type of stigma or some kind of perceived notion to medication, and it really does go back to that. It's about giving that person a chance. Maybe the medication is that one thing that connects them to another provider, another bridge, another resource that had they not been stable on that medication first, they never would have had the opportunity to walk through that door.
And Sharif, before we wrap up, anything that we should have asked you and didn't, or that you wanted to make sure you said today?
Oh, I appreciate it. I was actually just thinking about one thing that I wanted to share, and this is like to all those facilities out there that are considering setting up these programs, right? So we've said a number of times here that their facilities have been, there's opioids that are being brought in, contraband opioids. And this has been happening for decades. They've always been coming in, and it's hard to manage. You can keep these substances out as best as you can, but they still find a way in. And one thing that will really enhance the security of the facilities are these programs, because we're taking a drug problem that's ongoing, and we're sort of taking it out of the shadows and just providing like legitimate treatment for it. So it will make your facilities more safe and more secure, right? So there are so many benefits to these programs. Well, that's the only other thing I wanted to add.
That's such a great point,
Awesome.
right? And I love the taking it out of the shadows, because really what that's doing is reducing the shame and stigma, right, of this. Otherwise, it remains underground, and people don't get better in shame.
Sure don't. Thank you so much, Sharif, for all your contributions today. And I know anyone listening to this certainly got a masterclass in how we can treat people in these vulnerable populations.
Oh, thank you so much for having me. It's been a pleasure.
Thanks so much. It was wonderful. Everybody that's listening, it is our July episode. We will be back with another episode in August, and then we are ramping up and getting ready to do our recovery month in September, where we really do a weekly episode to celebrate recovery. So we welcome folks to kind of subscribe, follow all of the podcasty things if you don't want to miss an episode. Thanks again so much, Dr. Sharif Nankoe. We really appreciate you.
Thank you.
Thank you.
Thanks, everybody. Bye.